My name is Ms. Debanita Saha. I am Assistant Professor of the Department of Trauma Care Management, Yenepoya School of Allied Health Sciences, Yenepoya deemed to be University. Today, the topic I selected is Stevens-Johnson syndrome. Before going further into the topic, let's see the specific learning outcomes for today. After finishing the session, people should be able to explain what Stevens-Johnson syndrome and toxic epidermal necrolysis is. Now, commonly we will be using the terms SJS and TEN as a replacement of this. Now, my second objective is classifying SJS or TEN and mention the etiological factors. Explain pathogenesis and clinical manifestations of these, state about the Scott scoring system, list down the diagnostic criteria of SJS or TEN and outline the management protocol. So, what Stevens-Johnson syndrome actually is? It is nothing but a rare disorder of the skin and the mucous membrane, where there is severe detachment of the epithelial tissue of skin and mucous membrane. Depending on what percentage of body surface area, commonly known as BSA, is involved, we classify it as either Stevens-Johnson syndrome or toxic epidermal necrolysis. If more than 10% of body surface area is detached, we term it as SJS. If 10 to 30% of BSA is detached, there is an overlap between SJS or TEN. And more than 30% BSA detached, we will call it as TEN. Now, coming to the etiology or the most common causes for this are usually high risk medications. The very first one to be mentioned is allopurinol, and then there are other aromatic anticonvulsants, antibacterial sulfonamides, oxychem, or non-steroidal anti-inflammatory drugs. Other causes also include infections like mucoplasma infection. Then there will be chemical exposure, complementary or traditional medications exposure, vaccinations, and certain foods. There will be some idiopathic causes of SJS or TEN, so we do not know the definitive reason why the person has it. Coming to the pathogenesis, what exactly happens when the drug or irritant is introduced to our system? A drug or metabolite interacts with our immune system, which leads to immune system irritation and release of CD8 plus T cells and natural killer cells, which in turn will release toxic proteins like granulysin, perforin, and granzymes, causing cell death. Now, after this, further proceeding, it will lead to keratinocyte apoptosis, which leads to skin cells death. It basically means necrosis of the epidermal layer of the skin, and there will be severe skin detachment, which will ultimately lead to blisters. Then ultimately it can lead to widespread damage, severe inflammation, infection risk, and possible multi-organ failure. Now, clinical presentation of this disease. So first we have the prodromal syndromes. The prodromal syndromes usually mean the syndromes before the disease have already started. So first one is malaise. There will be general irritation, tiredness, then fever, then myalgia, which is muscle weakening or muscle pain, then sore throat and conjunctivitis. Then there will be cutaneous lesions, which usually starts from the face and thorax. Then mucosal involvement will be buccal, oronasopharyngeal and anogenital mucosa. Eye involvement leads to conjunctivitis. Along with its lead involvement, there will be inflammation of the lead or scraping away skin from the eyelid. Then there will be renal involvement in 20 to 30% cases. Then pulmonary involvement, which is slouching of the bronchial epithelium, pneumonia, and leading to pulmonary edema. Then gastrointestinal involvement, liver injury, and other hematologic abnormalities like anemia, leukopenia, and thrombocytopenia can also be seen with this disease. Ultimately, if not handled properly, it can definitely lead to bacteremia and overall central sepsis. Now, coming to the assessment part, we have a scale which determines what scoring to be given and assess the mortality rate depending on the score. It is known as Scoten scale. So what are the factors? We see here are 7 factors which are responsible. The first one is age. If the age is greater than 40 years, automatically the person will be more vulnerable and we score it as a point of 1. If it is less than that, we score it as 0. Heart rate, if the heart rate is less than 120, we score it as 0. Greater than 120, we score it as 1. Then serum blood urea nitrogen, if it is less than 28, we score it as 0. More than 28, we score it as 1. Next, there is detached or compromised body surface. Again, less than 10%, 0. Greater than 10%, as we already discussed, it is the starting of SJS, so we score it as 1. Then serum bicarbonate, if it is less than 20, then it is referred to as 1. If it is more than 20, then it is referred to as 0. Then serum glucose, if it is more than 252, then we refer to as 1, and if it is less than 252, we refer as 0. So now coming to the assessment part, after we have scored everything, we have to look what is the total score. If the total score is between 0 to 1, we give the mortality rate as 3.2%. If it is 2, the mortality rate goes to 12.1%. If it is 3, then the 35.3%. Then 4, it will be 58.3%. 5 or more we refer to as more than 90% mortality rate, and it is a very dangerous condition. So coming to the diagnostic part, clinical findings and history, there will be a sudden onset of painful mucocutaneous eruption associated with systemic symptoms and history of recent exposure to drugs. Then we will be doing drug casualty assessment like drug latency and drug notoriety. So we will be doing a background check on whatever the drugs have been given and what was the previous interactions with such drugs to have a more clear understanding of the problem. Then we will be conducting skin biopsies, which will include basal keratinocyte apoptosis in the early stage of the disease if we suspect positive SJS, which will evolve to full thickness necrolysis, and then separation of the epidermis will be present. Coming to the laboratory and imaging studies, there will be CBC, coagulation studies and metabolic panel, ESR and CRP studies as well. Bacterial and fungal cultures should be performed regularly. Then there will be polymerase chain reaction or serology, and we can find the definitive DNA of the problem. Then chest radiography should be done along with CT, or for more clearer vision we can always choose bronchoscopy. Coming to the management, so wound care for these symptoms will consist of both surgical as well as conservative approaches. So what we mean by the surgical approach? So surgical approach can again be of different types. Here it usually means scraping off the epithelial layer or removing the epithelial layer. So the first thing on surgical management will be manual scrubbing. So we will gently scrub off the skin, the dead skin tissues, so that the healthy skin tissues can be formed. Then there will be use of whirlpools. What is that? It will be a machine containing both temperature and motion control. So we can gently put the part or area of the body involved in that machine so that warm water can gently swirl away all the dead skin cells. Then there will be operative debridement, which usually involves use of scalpels and other tools to remove the dead skin cells. Now coming to the conservative approach or the anti-shear approach, which is commonly known as leaving the epithelium in situ or in place. So there in surgical we saw that we are usually scraping off the skin surface, but here we are keeping the damaged epithelium on place. It will be working as a shield for the underlying fresh tissue. So over that we will be using non-adhesive dressings which will be used to promote healing and reduce any kind of trauma. Then skin will be cleansed with sterile water or diluted chlorhexidine during the dressing changes. Then large blisters which will be present can be aspirated with a sterile needle, but the skin will be left in place. We are not going to remove the epithelial layer. Then dressings like silver containing nanocrystalline gauze or biosynthetic dressings will be used for better healing purposes. So for fluid and temperature management, for the first 24 hours, the fluid requirements will be estimated to be 2 ml per kg per body surface area involved. Then fluid should be titrated according to the patient's response and urine output as well. We will aim for a urine output of volume 0.5 to 1 ml per kg per hour. Room temperature should be maintained between 82.4 to 89.6 degree Fahrenheit. And the nutritional supplementation for the early catabolic phase, when the patient is still vulnerable for the catabolism of tissues, that time we will be going for 20 to 25 kilocalorie per kg per day, whereas in the anabolic recovery phase we are gonna increase it to 25 to 30 kilocalorie per kg per day. Now coming to pain control, for the mild intensity pain, which is less than 4 if we are doing in a scale of 1 to 10. So less than 4 we will be going with non-opioid analgesics, but if it is moderate to severe or greater than 4, it can be anything to 4 to 8, 9, 10, we will be going with opioids. Coming to prevention and treatment of the infections. So 30 to 50% of the patients with SJS or TEN usually develop bacteremia or sepsis. So this is one of the most common problem the people with SJS or TN face. Along with the disease condition, without improper care, there will be bacteremia or sepsis chances. So BSA involvement of more than 10% and hemoglobin levels of less than 10 per gram per dl and existing cardiovascular diseases are associated with increased risk of developing bacteremia. So these are the risk factors which will cause bacteremia, or these people will be prone to bacteremia without proper care. So what is our goal? Our main goal is prevention, active and clinical surveillance and prompt treatment of infections. So prophylactic systemic antibiotics are usually not recommended since it is a medication based hypersensitivity reaction. So we are not usually giving any prophylactic systemic antibiotics. We will give antibiotic based on the symptoms. So prevention of infection involves usually sterile handling and skin antisepsis. Then repeated bacterial cultures, blood catheters and gastric urinary tubes changes will be done. Then surveillance for clinical signs of sepsis. So the clinical signs of sepsis or bacteremia include hypothermia, confusion, hypotension and reduced urinary output. Hypothermia and elevated procalcitonin greater or equal to 1 mcg at the time of blood culture usually shows positive predicative of the disease. Then treatment usually we will be going with antibiotic choice, which will be directed by culture results, not prophylactic antibiotics. It will be directed by the culture results whenever possible, usually for Staphylococcus aureus and Pseudomonas aeruginosa. Commonly isolated pathogens are these. Then plasmapheresis can be done with conjunction of other therapies. What is this? This is the separation of patient's infected plasma and replacement with fresh plasma. Coming to adjunctive pharmacological therapies. Now we have IVIG or IV immunoglobulin. Then we have TNF alpha inhibitors, which will be given usually as a single dose. Then we have cyclosporin, which is a very crucial medication in such cases. Then we have corticosteroids like prednisone. Then to summarize all this, we can say that SJS or TN is nothing but severe infection or hypersensitivity reaction which has occurred in the skin or mucosal membrane due to medication allergies or in other chemical components, or that can be due to any other food, or there are some idiopathic causes as well. The usual drug involvement are sulfonamides, anticonvulsants, and NSAIDs and allopurinol. So infection is a quite less common cause compared to those drug interactions. Pathogenesis will be delayed type 4 hypersensitivity, which leads to release of CD8 T cell and which will ultimately lead to skin cell death. Assessment, we use the Scotten score, which has 7 components for predicting mortality. Signs and symptoms include fever, malaise, and then other blisters. So these are the most common signs for understanding for bacteremia. If we are assessing bacteremia, we can see the hypothermic condition, then reduced urinary output. Then management includes immediate drug withdrawal, the ICU or burn care unit management, fluid electrolyte support, wound care, analgesia or IVIG or cyclosporine. No steroids will be given routinely. So these are my references. Thank you.